Hi, everyone. My name is Brandy Thomas, and I'm the producer for Texas Fertility Center. Thank you so much for joining us for tonight's webinar on PCOS. In just a minute, I'll be bringing on Dr. Susan Hudson and Dr. Erica Munch to have them talk to you guys about everything with PCOS. But before I do, I wanted to go over a few things regarding how this webinar works, and also let you know this is actually part of a monthly series that we do. We cover a different infertility topic every month. So be sure to check out our website. It's txfertility.com. And the webinars, if you scroll down on the homepage, you'll see the next upcoming ones listed there. So keep coming back to these. We love seeing you guys. I'm sure there's a few of you on here who have been at the past webinars. So thank you so much for the support. And we really hope that you guys are getting a lot of good value and information out of these. Now, as for how this webinar is going to work, Dr. Susan Hudson and Dr. Erica Munch, they're going to come on and talk a little bit about PCOS. And then in the middle of the webinar, probably about 15 minutes in, they're going to stop to answer some questions. If you look to the right-hand side, you'll see that there's a questions panel there. So you can submit a question at any point about PCOS, and then that is when we will go ahead and answer them. And we'll try to get to as many as we possibly can. Depending on how many we get, we might not be able to cover them all, but most of the time we are able to. So be sure to go ahead and use that. And just know all questions are submitted and answered anonymously. So you don't have to worry about any of your information being shared with anyone else. They're also going to do another question segment at the end of the webinar. So if you have any questions you think of after that midpoint, go ahead and just put it in there and we'll answer it. Alrighty, I think that about covers it. So with that, I will go ahead and bring on Dr. Susan Hudson and Dr. Erica Munch.
Good evening, everybody. I'm Dr. Susan Hudson.
Hi, I'm Dr. Erica Munch. Thanks for joining us tonight.
And we're going to talk a little bit about PCOS. So I'm going to start off kind of talking about what exactly is PCOS. So first of all, it's more than just a whole bunch of letters put together. PCOS stands for polycystic ovarian syndrome. Now, before we get kind of into the minutia of what exactly PCOS is, I always like to make sure that people know that, first of all, it's actually a very poorly named condition, in my opinion. When we as doctors talk about cysts, and I know a lot of our patients out there have had issues with cysts on their ovaries, it's actually a very different situation than what ladies with PCOS typically have. So on a woman's ovaries, there are little fluid-filled follicles. Those are the little sacs that contain the eggs. Now, when we kind of talk about cysts, we actually are usually talking about something that's greater than 2 centimeters that isn't supposed to be there at that particular point in time. With ladies with PCOS, they often have lots of little follicles that are kind of in this resting stage. So, like I said, I just like to make sure we all know what the terminology is. So just kind of starting off with that. So first of all, what is PCOS? So first of all, it is a diagnosis of exclusion. And what we mean by that is that there are certain things you need to have to potentially have this diagnosis, but there are things that we need to exclude. Okay. So Erica or Dr. Munch, what are some of those things that we need to exclude when we're looking at this diagnosis?
Right. So it's a very good question. I'm glad you brought up the point about the cysts, because I find a lot of patients probably come to us both and say, my doctor told me I had cysts on my ovaries, and that's a different cyst than your great aunt Sally had on her cyst. She had to have her ovary taken out, and these cysts are actually just more evidence of the underlying problem, which is most women that have PCOS don't get periods regular. And like Dr. Hudson said, that can be from a variety of conditions. PCOS could be one of those, but there could be other problems that are causing people not to get periods. Their thyroid might be out of whack, and they might have an underactive thyroid and really have delayed periods, months, in between cycles. They could have problems with some of like the receptors in their ovary and how they handle insulin and other male type hormones that we all have as women, but affect the ovary a little bit differently. There can be some less common endocrine disorders where certain enzymes are missing, and we don't end up getting ovulations to happen when certain parts of the chain are missing. And then, some women actually have diminished their ovaries are not capable of making eggs because they're running out of eggs, right? And so that's the big one that I find, that some women have been told that they have PCOS because they have irregular cycles, but it's actually because they're running out of eggs more quickly. So some of the tests that we'll talk about tonight are helping us figure out, are we in the category of having plenty of eggs, but the ovaries and the brain not signaling the right way to each other? Or are we in a position where maybe the brain isn't signaling the right way, or the ovaries are really struggling to deal with that signal?
Absolutely. Absolutely. So you kind of talked about some of the tests that we look at when we're evaluating a person for PCOS. And one of the big things we look at is ovarian reserve testing. Just as you mentioned, generally we'll check an FSH and estradiol level. FSH is the hormone your brain produces that talks to your ovary, and estradiol is what the ovary produces that talks back to the brain. And quite a few of us nowadays do what we also call an AMH level, or anti-Mullerian hormone. And that hormone gives us a little bit more information on quantity of follicles. So it ties it all together for us. We'll also check your thyroid function. So generally at least a TSH level. Some physicians may check some additional thyroid panel type things. We also want to look for a little hormone called prolactin. Prolactin is produced by your brain, normally makes women get breast milk after they have babies. But if it's a little bit off, it can make women have irregular periods, and it's going to be treated in a different way than someone who, quote, just has PCOS. We're going to look for something called 17-hydroxyprogesterone, which would be a hormone that you may produce in abnormal levels based on kind of your genetic makeup. We will also look at some hormones secreted by your adrenal gland, like DHEAS. Testosterone level, I think we've all heard about that. As Dr. Munch mentioned, testosterone is one of those male hormones, but all females have those hormones, and vice versa. So it's all kind of in proportion, and we're making sure that there isn't something that we should be missing and treating very differently.
Mm-hmm. One of the things that I've seen patients either ask me about, or sometimes they've had, and they say, well, the internet says that when they look at my brain hormones, there's a hormone called LH and there's a hormone called FSH. And if this one is twice the level of this other one, that means I have PCOS. And what do you think about that? And really remember, those brain hormones, depending on what part of your cycle you're in, they could be very high, they could be very low. And it's really important for us as the doctors to realize like what part of your cycle you got those drawn in. Nowadays, the diagnosis of PCOS isn't really made on the ratio of those two. But I will say that women that have PCOS oftentimes will have a very high LH. And the reason why I mention that is because the LH is actually the thing that is detected on the ovulation predicting kit. So some of my patients will have come to me frustrated beyond belief, which is understandable because they've gone out and they've bought these ovulation predicting kits, and they say, Dr. Munch, I'm testing these every day and I am getting a positive every day. And that's about as unhelpful as getting a negative every day, because your body, for women that have PCOS, is sending out this signal like almost all the time, or constitutively, right? And we don't know, and the ovary clearly doesn't know when it's time to make those eggs come out. So LH is something that you'll see sometimes get checked. And if your LH is elevated, oftentimes it means that those OPKs are not going to be a good way of figuring out when you're ovulating. And fortunately, in our reproductive world, we have lots of very easy ways of working around that to know when your most fertile window is.
Absolutely. Absolutely. So kind of taking a look at some of the things that we do expect to see in somebody who has PCOS, we kind of have what I consider the top three, the things that we're really looking at when you're telling us the story that we're like, this sounds like PCOS. So first of all, ovaries that appear polycystic on ultrasound. Now, what exactly does that mean? Well, generally it means you have at least 12 follicles that are at this resting stage that we can see on at least one ovary. You don't have to have this on both ovaries, okay? In some people, the follicles are be a little bit more well distributed, but the classic picture of somebody with PCOS is someone who has what we call a string of pearls sign. So you have a picture of your ovary, and all around the outside, you see this little round, looks like a necklace of pearls around kind of the center part of the ovary. And so that's the classic look. Not all PCOS is the same. So I do like to make sure people understand that there are some people who have PCOS and there's some people who have PCOS. and so that's some of that's going to
are just 20 years old that have amazing looking ovaries, right? So just because you've been told that you have cysts on your ovary, again, that cyst is just a fluid filled sac. And sometimes that sac has a job to do and we call it a follicle. And sometimes it's, as she said, an aberrant part of the cycle where we don't expect it. And that's usually when it's more troublesome. So, and feel free to ask questions, guys, throughout, send some up so that we have, can answer those questions, but keep going.
Absolutely. So, and the second thing that you may have as a symptom is having irregular periods. Okay. And those can sometimes be periods that come really close together and you're having lots of bleeding all the time. Or you could go 2 months, 6 months, a year without having a period. And I know that's what a lot of women dream of. But it's not necessarily a sign that everything's working correctly. And then the third symptom is signs of what we call hyperandrogenism. So a little bit too evidence of too much male type hormones. That can either be from blood tests, like some of the things that we talked about earlier, or it could be things like more than the average amount of acne, increased hair growth. Sometimes women with PCOS have hair thinning or kind of male pattern baldness and things like that.
Mm-hmm. Yep. I always ask, hair kind of in the places you don't want it to, right? On your lip, chin, sideburns, belly button, toes, places where that many women will have hair, but a lot of them will say that they have to wax or pluck or shave or have had electrolysis done to remove that unwanted hair growth. That's a common sign. And sometimes, if you've had evidence of that already, we don't always need, or your doctor doesn't always need to get the blood testing, because even if your testosterone level is normal, in women that have PCOS, your body is just, it doesn't always have the hormones that sop up that extra testosterone and cause the testosterone to have more of an effect in your case.
Absolutely. Well, Dr. Munch, would you like to kind of talk about what are some of the options for treatment for ladies who are seeking fertility care with PCOS?
Right. So there are a lot of different ways that we address that. And before I go into thinking about women that are fertile, just kind of taking off my REI hat, as a fertility specialist, I'm going to put on my good gynecologist hat. Depending on what stage of life you're in, some women, they say, well, what's the treatment for PCOS, right? And PCOS it's not a disease you catch from somebody. It's not something that, there's a magic pill to make it go away. It's kind of a constellation of symptoms, and it's kind of a reflective just of an overall state of an inability to get those eggs out at the time we expect. So when you're not trying to get pregnant, you may not care that you don't get a period except once a year, right? I mean, that doesn't sound fantastic, right? But actually, there are a couple of health conditions that can be associated with PCOS that we want to make sure we're keeping at bay, or that we're preventing, adverse consequences of those, maybe desirable side effects. So that way we keep you in good health. So when you are ready for your family building, like, you're going to live 80 years and see those children and grandchildren to adulthood. So when you're not trying to get pregnant, the way that most people will treat PCOS is by making sure that that there's no overgrowth of the lining inside your uterus, right? The most easiest, convenient way to do that, especially if you're not really wanting to have kids at that time, is to be on some kind of birth control. And that could be pills, that could be patches, a NuvaRing, the injections in the arm, it could be the implant, it could be an IUD. There's lots of different ways to prevent that overgrowth in the uterus. Some women that have PCOS also have insulin resistance, though, and at more risk of something we call metabolic syndrome, where they can have prediabetes, elevated blood pressure, increased abdominal fat, and we want to and cholesterol problems. And so sometimes we'll check for those things during the PCOS evaluation, because it's our responsibility to make sure, hey, these things might be in your future, but you're kind of in that pre-diabetic range. Let's make sure that you're doing what you can with your diet. You're working with your physician to get your blood sugars under good control. So that's what we do when you're not trying for pregnancy. There are things that we can do for women that are trying to get pregnant that clearly don't involve birth control methods, because people can't just be on birth control pills and expect that their ovaries are going to respond. So
Erica, before we do too much, why don't we answer a few questions?
Yes. All right. So one question, how often should we get blood work done? Once you've had the diagnosis made about PCOS, aside from checking a couple of things that are important in pregnancy, there probably isn't a whole lot of blood work you need to keep having repeated frequently. When we know that your ovarian reserve is good, once you've entered a stage of treatment where we know what's working for you as far as getting your ovaries to develop, we don't have to keep checking your AMH, because if it was really high and a good bank account level in the ovary, it's probably still going to be fine, 3 months from now or 6 months from now. Thyroid is important for pregnancy. We want to make sure we're checking that every 3 to 6 months, depending on how quickly you're getting pregnant, and making sure we're at the appropriate pregnancy values for thyroid hormones. As far as other things, if there's something that comes back abnormal, we want to follow up on it until it gets into the normal range. But once a diagnosis is made with PCOS, we have our answer and we can move on to the next step. You should feel like you need to keep getting these things checked, because PCOS, like I said, it doesn't magically go away. We just treat it in different ways depending on what stage of your reproductive life that you're in. One question that I get a lot, and I've seen a couple of times here on the question panel, is whether or not there was anything that somebody did to cause PCOS. Like, is there certain things in their diet that caused PCOS? Is it the fact they were on birth control forever and ever, and then they came off and they're trying to get pregnant and now their periods don't come, and somebody tells them they have PCOS and they say, the birth control pills, messed me up. And I get that a lot. For better or for worse, there's nothing you can do to bring PCOS on. Some women are just more prone to developing it. And some women, especially if they carry extra weight and they're considered in the obese or overweight category, may find that those slight changes in weight will predispose them to having more irregular cycles. And some women that have PCOS, not all, but some women with PCOS will notice as they change their weight and they decrease their weight, or they start eating foods that are less taxing on the insulin system, as it were, they start eating more or avoiding the refined carbohydrates and start pairing proteins with carbohydrates. And they will actually notice that they'll get some degree of regularity in their cycles. Not everybody, right? This isn't a one-fits-all policy, but there's certainly nothing that you could do to bring this on yourself. And I think that's important to realize, right? That this is not a lifestyle choice of having PCOS or not. It's a medical condition, and we want to treat it appropriately.
One thing that I like to explain to people is PCOS is kind of the way that you're wired. I have red hair. I will always be a redhead through and through, and it's part of who I am. And PCOS is a condition like that, in my opinion. It is part of who you are, and we manage it in different ways, like Dr. Munch was mentioning, at different phases of your life. Okay. And that kind of feeds into another question we have about, do we fix my abnormal hormones if I have a high LH to FSH ratio or a higher testosterone level before going into fertility treatment, whether it be ovulation induction or IVF or those types of things? And really, we don't, because those hormonal imbalances are part of who you are. And in some respects, those are part of the things that often make you be a very good responder to fertility treatments. And so we can't fix it. There's not anything that we can give you that's going to make everything be exactly where it should be and still get you down the pregnancy column. and so I think it's important to focus on what direction you're going. Are you looking for kind of wellness and general health for your everyday life, or are we looking at focused really on the goal of getting pregnant and having a baby right now and that type of thing?
Mm-hmm. One thing that some people know about themselves and about the diagnosis of PCOS, like I said, is that some people are more sensitive to blood sugars, exogenous sugars that are coming from their diet, and have been told by their physician that they need to be on metformin, right? They say, you have PCOS, you should be on metformin in order to get pregnant. And that's, true and not true. There were not as many good medicines as there are now to help women who have PCOS make eggs or get the brain and the ovary to be talking better to each other. So it was not uncommon a long while ago to put people on metformin. I would say nowadays it's more common for people to be on metformin that truly have those pre-diabetes conditions or really show us that they have a high degree of insulin resistance, because there may be some benefit to putting them on medicines that help their body be more sensitive to insulin, and that might help with egg development. But it's not a blanket statement that everybody that has PCOS needs to be on metformin, because we have many other ways of being able to help with ovulation induction. As far as other metabolic issues that are associated with PCOS, like Dr. Hudson was saying, part of them is who you are, right? The fact that you actually have really high ovarian reserve is a good problem in my book, because it means that I can get eggs. I can't make eggs out of thin air. So if you have them, that's, already a great starting point for us. The other metabolic issues associated with blood sugar or high blood pressure or cholesterol really tend to be approached more in a systematic way based on the particular condition. So there are not medicines that I use as an REI that would decrease cholesterol or fix the problem of PCOS and bring down your cholesterol, but you and your primary care doctor would talk about dietary changes related to why your cholesterol is elevated and what you can do. We actually don't want you to be on cholesterol medicine when you're pregnant, so please don't go out and do that. Other things as far as, again, central adiposity or carrying extra weight around your midsection is associated with metabolic syndrome and insulin resistance and having those, gestational diabetes down the road. So oftentimes your primary care physician might advise you to look into strategies that will help reduce that extra growth around the midsection, because in doing so, you're going to reduce your risks of those other things, especially later on in pregnancy.
So one of our watchers tonight wants to know, if I have PCOS, do I need IVF to get pregnant? So I think that's a great question. And I think that's the one thing that a lot of people are very nervous about. And the nice thing about PCOS is most people with PCOS are going to be able to get pregnant without going to IVF. Classically, we would use medications like clomiphene or letrozole. Letrozole is a little bit newer than clomiphene. Clomiphene, I think, has been around for 60 years or so. Yeah, 60, 70 years. It's been around for a long time. But letrozole has been used probably for about the past 15, maybe 20 years to some degree, and even more so now that we actually have evidence to show for people with PCOS, letrozole does tend to have higher chances of pregnancy. And so oftentimes, if everything else checks out right, talking to your doctor and potentially doing a few cycles of one of these two agents to help you get to ovulate will often result in pregnancy. Now, being fertility specialists, we also recognize that in fertility, it is not uncommon to have more than one thing going on that causes a couple to have trouble conceiving. So most of the time in our practices, if you come to us with what sounds like PCOS, we're still going to check out your fallopian tubes. We're still going to check out your partner's sperm. We're going to check out the other big offenders of things that can cause people trouble getting pregnant, because we don't want to be going down the wrong path. We don't want you to be taking medication for 2-3 months and then find out, oh, your tubes are blocked. We've been doing the wrong treatment. We really like to look at the whole puzzle before going down one of those paths. Now, looking at IVF is going to be the right thing for some people, and it's not going to be the right thing for others. Now, IVF is a great option for people with PCOS who haven't been successful with less aggressive treatments, or people with PCOS who may have tubal issues, may have male factor where maybe we don't have enough sperm to give good chances of pregnancy with either intercourse or insemination, and those types of things. So really treating the whole picture is what we're really looking at. I always like to think of that we want to do the least invasive, but the most appropriate. Sometimes that means IVF. But a lot of times we're able to get by with much less invasive and less expensive treatments.
Yeah, we certainly want to be very accurate, in our diagnosis, because most people coming to us with PCOS, they already know they're not getting a period. They know that they're probably not releasing an egg. They're not getting a fair chance of pregnancy each month. And so a lot of times they're just like, okay, well, I'm ready for my Clomid prescription. And that's great if that's the only thing that's going on and your body responds to Clomid, right? But there's two things then that doctors like myself and Dr. Hudson have to figure out is, A, is that the only thing going on? And B, what are the things that are making you get irregular cycles, possibly besides PCOS, that might interfere with how my medicines work, right? So if you have a thyroid problem that's way out of line and I give you Clomid, it's not working. And if it would be negligent for me to not check your thyroid and say, hey, this could be a contributing factor, and we get your prolactin under good control, and bam, all of a sudden now you're finally responding to medicines that maybe you had gotten, before and years prior that didn't seem to be working, and hey, now they're working. Similarly, having somebody be on letrozole or Femara is not going to change the fact that the sperm numbers might have been too low, and you're still not getting a fair chance, and we need to do things to help augment that chance. Now, as Dr. Hudson said, the most common ways of moving forward when somebody is not releasing egg is to try to do generally simple things first to see if we can get you to make an egg, right? The goal is to go from making 0 eggs to making 1 egg or maybe 2 eggs, but not to try to make 15 all at once. So what we do is we use these medicines to help the brain and the ovary talk better to each other. One of the things that we do in an REI practice that is less common, especially with primary care physicians that may not feel as comfortable using these medicines or not have the ability in their offices to monitor, is that we do want to know how these medicines are working, right? Some women that have PCOS are fairly resistant to some types of oral medications or at the doses that are more commonly used in the community. And so we don't want to just, give somebody a prescription and say, call me in 6 months if it didn't work, right? Because that's frustrating. You've already waited at least 6 months, before you're coming in to see somebody like us. So in those kinds of settings, it's really important to know that your body is responding to the medicines. And it shouldn't take more than about a week and a half to make an egg. And if you haven't made an egg by then, we don't need to wait another 3 or 4 weeks to see if it's going to happen. We're going to move on to the next step, which is trying a different medicine or increasing the dose or trying this other combination of things. So that way we're very, you want to find somebody that's going to very proactively take you through that process, because you're already feeling like you're spinning your wheels. You don't want to feel that way often. Now, one of the medicines that you hear about in fertility treatments are medicines that are actually used, they're injections. There are some injections that help make eggs come out, which are good, and we use those often with women with PCOS. But there's another type of injectable medicine that you hear people using that helps stimulate the ovary to make eggs. And those are good medicines, but they're kind of like playing with fire in women that have PCOS, because you have so many eggs. And if we use these medicines, we tend to need to use them at very low doses, slowly over time, to see if we can get one of those eggs to kind of catch the wave and ride it to the shore.
It takes a lot of patience.
Takes a lot of patience. And we want, again, 1 or 2 eggs. We don't need 5 and 6 and 8 eggs, because then the risk of multiples is too high. In those cases, for women that are struggling to respond to the oral medicines, but those injectable medicines, even at low doses, are getting them to over respond, that's when IVF might be a good tool, right? Because again, the problem's not the eggs, right? There's plenty of eggs. We just need to do it in such a way that gets you safely pregnant. And some women with PCOS can go through IVF, get multiple eggs. We're not going to put them all in at once. We're going to take the best quality embryo, do a transfer, hopefully establish a pregnancy, but then they've got other embryos cryopreserved so that later on down the road, all they have to do is another embryo transfer. They don't have to go through IVF again, all the injections and the stress about coming back and forth for appointments. And they're able to go through a single IVF cycle, but multiple embryo transfers to be able to satisfy their family building, over the next 5 to 10 years, and do so in a safe manner. And then they can get on the birth control and not worry about ever getting periods ever again. So there's a lot of different tools we have in our box. And that's why you may hear your physician talk about these medicines, and there's certain reasons we use them at certain times.
Very good. Very good. Well, let's do some more of these questions we have. So we have one watcher that's asking, does the birth control treat the metabolic issues associated with PCOS, or is there anything further that can be done other than diet? So birth control pills don't fix the metabolic issues. Okay. Really, the metabolic issues are going to be fixed with things like diet, exercise, weight loss, watching what you're eating. And people with PCOS do tend to do well with kind of lower inflammatory type diets, either looking at things like Mediterranean style diet. If they're trying to lose weight, sometimes a keto types diet works well, but I always advise make sure you do that under a doctor's care, because there's some people whose bodies respond better to that than others. And there are some supplements. I've had some good success adding in myo-inositol to a number of my PCOS patients. I actually have I was actually talking earlier today, I've had a decent number of people who have gotten spontaneously pregnant in the time between I started them on myo-inositol. We started doing the fertility evaluation, and they show up to be pregnant because they started ovulating. And so that's kind of a nice resource. Now, it's not a miracle, pill or anything like that, but it is something that does seem to kind of target some of those metabolic things that we are seeing in PCOS. And I do like to make the mention that a lot of our patients with PCOS, not all of them are going to have weight issues. Some people with PCOS do have weight issues, some people don't. But those who do, I want you to know that I always hear, I'm working out as much as my friends, I'm dieting more than they are, and I'm still not losing weight. An important thing to understand is the little mitochondria, which are the powerhouses of your cells, in ladies with PCOS are actually different than they are from other people. So what you're perceiving as I'm having to work harder to achieve my goal, it is very real. Okay. And so I think there's a lot of strength in the power of that knowledge, knowing, yes, I may have to work harder, but you can get to that goal. You really, really can. And I say this to lift you up in that what you are feeling is not just a false perception. It is really in people with PCOS do have to generally work harder to achieve those same goals.
Yep. I tell my patients, I say, you notice that you can't get away with eating the same stuff that your husband does or that your friends do and get away with it and not put on the pounds, right? And your body is just, it metabolizes things in a different way, especially with that potential for insulin resistance or mitochondrial dysfunction. As far as like what weight goals should be or an ideal BMI or things to consider as far as weight. Now, to be fair, there are some people that seem to have no problems getting pregnant no matter what their weight is. But when we do notice that weight is an issue, when somebody's infertile, we have to say, could this be an underlying issue in you guys' particular case? The best, most optimal BMI and weight and kind of taking all things into account for pregnancy is generally a BMI of less than 30. So when they've looked at studies who are of women that are underweight, regular weight, overweight, and obese, the women that are overweight, which is a BMI of 25 to 30, and the women who are normal weight, which is like 18 to 25, they actually have about the same chances of pregnancy and miscarriage and stillbirth. It's really when you have a BMI of over 30, which is technically by World Health Organization considered obese, that's when we start to get into more of those adverse outcomes as far as miscarriage rate, birth defects, stillbirth, all the things that we don't want for any of our patients. So when encouraging, my patients to say, like Dr. Hudson said, I know you're going to have to work harder sometimes to get to these goals. But I tell them you don't have to be rail thin or perfect ideal weight, in order to have the best optimal chances for pregnancy. Certainly once you're pregnant, we don't want you losing any more weight, right? But anything you can do prior to that point is nothing but helpful, especially when it comes to thinking about decreasing the risks to that baby and also minimizing your risks of developing blood pressure or blood sugar issues like gestational diabetes or preeclampsia in the pregnancy. A couple of questions about other things, how PCOS could affect other parts of your fertility, right? PCOS doesn't cause your uterus not to function. It doesn't cause your tubes to be blocked. It certainly doesn't cause sperm issues. But like I said, most REIs are going to evaluate and do, leave no stone unturned when it comes to evaluating everything. So certainly, just like putting somebody on Clomid is not going to fix a blocked tube. We want to make sure that we're identifying all the potential issues and being very targeted and precise in whatever our treatment goals are going to be moving forward. I got a question recently about working with a nutritionist. I think that's amazing. I tell patients, that are struggling with their weight and the way they eat, I say there's kind of 3 different ways we can look at this. We can send you to a nutritionist and have you kind of come up with some modified dietary plans, because 90% of weight loss is diet and there's a little bit of exercise, but it's mostly about what you eat. And some people want to see a nutritionist to help with that. And that's amazing. And a lot of insurances will cover that kind of evaluation. Some people want to do more of like a medical weight loss where they go to a clinic and get prescribed medications. And if that's the route they want to go to, great. There's resources we have for that. Some people find it's more of a behavioral thing. And they say, I'm eating mindlessly and the pandemic's happening and I'm just eating all the time. And I really just need to, get in a better frame of mind. And there's, of course, different resources for that. So I think whatever you have that can be, somebody on your team to help you get to those goals, that's great. I think that's a wonderful resource and you should, definitely explore it.
So we just received a new question asking about being treated for infertility with a BMI between 32 or 33. And just sounds like some frustration about gaining weight and periods irregular than they have been before. And what we mentioned earlier is that there is a certain group of people with PCOS that kind of have that genetic predisposition. And as you go through life and you gain weight, that's when people start having more issues with those periods become irregular and start having more hair growth, different things like that. And in those people who specifically, they did have normal periods, they've gained weight, now have irregular periods, that's the major target group that weight loss is often going to kind of restore you back to normal, because there's kind of a little internal mechanism that kind of flips on and flips off at some specific target rate. And sometimes losing just 5% of your body weight will get you back into a regular cycle where you're releasing an egg on your own and help you get back into that regular fertility. So any other, I think that kind of covers most of the questions that we have for this evening. But I want to thank all of you for joining us this evening, and we look forward to seeing you on our next webinar. Thank you so much.